Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. This is Ahmad Abuzinadah, Associate Professor of Neurology, and today we are going to talk about approach to a patient with headache, and this is mainly basic talk about how do you take history and do physical examination to formulate your initial diagnosis and investigation and management. So these are my disclosures. The objectives of today's lecture include the following. The student should be able to generate a differential diagnosis for secondary headache disorders, generate a differential diagnosis for primary headache disorder, use the differential diagnosis to guide the history taking, recognize secondary headache disorder red flags, recognize the signs of secondary headache disorders, recognize primary headache features, order appropriate investigation, and initiate initial management. So we are going to talk about general principles for history taking. In order to take a good history, you need to have a good differential diagnosis. Without differential diagnosis in mind, the history might be less informative because usually you ask about the symptoms of your differential diagnosis. And in cases of headache, we need to know the life-threatening condition that present as headache, and we need to ask about their symptoms, and we need to look for their signs. And these, what we call red flags. Also, if the headache is not suggestive of secondary headache disorder, then we proceed with the second step, which is we ask about the symptoms of primary headache disorders. So for simplicity, we can make this rule. We first ask about the red flags in the history. That will help us to know if there is secondary headache disorders or not. Then we perform neurological examination. And if there were no red flags in the history and the neurological examination was normal, then that make us think most likely it is primary headache disorder. If there is a red flag in the history or the neurological examination was abnormal, then we need to look carefully and investigate for secondary headache disorder. Remember, any rule in medicine has exceptions, and most rule in medicine may be correct in 80 to 90% of the time, but not 100% of the time. So, what are the causes of secondary headache disorder, or what is the differential diagnosis for secondary headache disorders, which is, by the way, the same as the differential diagnosis of thunderclap headache. First, subarachnoid hemorrhage. Second, meningoencephalitis. 3, carotid artery dissection. Number 4, hypertensive encephalopathy, which is also called BRIS. Hypertensive encephalopathy, also called BRIS, which is posterior reversible encephalopathy syndrome, because most of the time hypertensive encephalopathy affects the posterior part of the brain, mainly the occipital lobe. Number 5, vertebral artery dissection. Number 6, cerebral venous sinus thrombosis. Number 7, reversible cerebral vasoconstriction syndrome, also known as RCVS. Number 8, pituitary apoplexy. Number 9, giant cell arteritis. Number 10, acute stroke, whether it's hemorrhagic or ischemic. Number 11, raised intracranial pressure and acute hydrocephalus. For example, if there is mass inside the ventricles that might obstruct the ventricle and causes hydrocephalus, or any causes of raised intracranial pressure such as intracranial hemorrhage or masses. Then the definition of thunderclap headache is the headache that reaches its maximum intensity within 30 seconds from the onset of headache. So the causes of primary headache disorders include number 1, migraine, number 2, tension headache, number 3, trigeminal autonomic cephalalgia. And conditions under trigeminal autonomic cephalalgia include number 1, cluster headache, number 2, paroxysmal hemicrania, number 3, hemicrania continua, number 4, SUNCT, which stands for short-lasting unilateral neuralgiform attacks with short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. Then, when we start taking history, we start about the red flags, and there is an acronym for the red flags that might give us a clue about secondary headache disorder. The acronym is called SNOOP4, SNOOP4. So now we are going to talk about these symptoms and what they make us think about. So the first letter in SNOOP is systemic symptoms, and that includes fever, which make you think of meningoencephalitis, or weight loss, which might make you think of intracranial metastasis such as leptomeningeal metastasis. The second letter in the acronym SNOOP is N, which stands for neurological symptoms. First, under neurological symptom is confusion, which might make you think of meningoencephalitis or cerebral venous sine thrombosis, or hypertensive encephalopathy. The second thing is double vision or diplopia, which might make you think of subarachnoid hemorrhage, because usually subarachnoid hemorrhage occurs due to posterior communicating artery aneurysm, or in abbreviation we call it PCOM aneurysm, because PCOM, the posterior communicating artery, usually run beside the third cranial nerve, and if there is an aneurysm that compresses the third cranial nerve, that might lead to the diplopia or double vision. Also, another neurological symptoms is seizure. So that might make you think of cerebral venous sine thrombosis or hypertensive encephalopathy. The other symptom under neurological symptoms, focal weakness, for example, difficulty to move one arm or one leg, that might make you think of subdural hematoma or stroke secondary to carotid dissection or intracranial hemorrhage. And also another important symptom under neurological symptoms is vision loss or blurry vision, which might indicate hypertensive encephalopathy or breast posterior reversible encephalopathy syndrome or cerebral venous sine thrombosis or raised intracranial pressure due to mass or idiopathic, for example. Then the first O in the acronym SNOB stands for onset, sudden onset, which we mean by it thunderclap headache, which make you think of subarachnoid hemorrhage. The second O in the acronym SNOB is onset after age of 50, which make you think of giant cell arteritis. And once you think about giant cell arteritis, you need to ask about jaw claudication, meaning pain in the jaw after eating for 5 or after chewing for 5 minutes or 10 minutes, or shoulder pain or hip girdle pain, because usually giant cell arteritis is associated with polymyalgia rheumatica that might present as shoulder pain or hip girdle pain. Then the first P in the SNOB 4 is precipitated by Valsalva. For example, if the patient headache gets worse with coughing or sneezing or straining, such as constipated patient when they have bowel movement, that might indicate the presence of raised intracranial pressure. And you might need to ask about, for example, tinnitus if you think of raised intracranial pressure. The second P in the acronym SNOB 4 is papilledema. Papilledema is physical sign, but the symptom that usually associated with papilledema is transient visual obscuration. What do I mean by transient visual obscuration, or TVO? Most of the time, the patient, they experience loss of vision for 5 to 10 seconds if they bend and then stand up from bending position. So if the patient bent forward, then the patient stood up or corrected his position to upright position, the patient might tell you, I lose the vision for 5 to 10 seconds up on standing up after bending position. And the other P in the acronym SNOB is postural change. So if the patient has headache, only when the patient is standing, while the headache disappears while the patient is lying flat or supine, that make you think of CSF leak headache, or also it's called intracranial hypotension, CSF leak headache or intracranial hypotension. Usually if the patient has intracranial hypertension or mass in the brain, the headache is the opposite. Usually it occurs with lying supine and disappear with standing up. The last P in the acronym SNOB is progressive. If the headache is progressive, you might think of expanding mass. If the patient did not have any one of the primary headache disorder feature, then if the patient didn't have any one of the red flags or any of the secondary headache disorder feature, then we move on to the next step, which we ask about the feature of primary headache disorder. And one of the most important things is the duration. If the headache duration more than 4 hours, that make you think of migraine. If it is less than 4 hours, you might think of cluster headache. So the top 3 questions that you need to ask, and what do they make you think of? Number 1, you ask if the patient, if you have severe headache attack and you don't take medication, does the headache last more than 4 hours? If the patient says yes, it lasts more than 4 hours, that make you think of migraine or tension headache. If the patient says no, it doesn't last for more than 4 hours, then that make you think of cluster headache, because usually cluster headache lasts 30 minutes to 1.5 hours. The second question, you ask the patient, if you have severe headache attack and you don't take medication, can you continue with your daily activity? If the patient say no, I cannot continue my daily activity, then that make you think of migraine. If the patient say yes, I can continue with my daily activity, then that make you think of tension headache. The third question, if you have severe headache attack and if you have severe headache attack, do you prefer to go to a dark room and sleep? If the patient say yes, I prefer to sleep and go to a dark room, that make you think of migraine. If the patient says no, that make you think of tension headache. Also, we might ask more about the symptoms suggestive of migraine, and there is an acronym for migraine headache symptoms. It's called SULTAN. S stands for severity, and U stands for unilateral. However, we have to keep in mind that 40% of migraine patients, they might have bilateral headache. However, 60% they have unilateral headache. L stands for light sensitivity, meaning the patient might have photophobia and phonophobia, sensitivity to light or sensitivity to sound. T stands for throbbing or pulsating headache. However, we have to keep in mind that 50% of migraine patients, they might have non-throbbing or non-pulsating headache. A stands for activity makes the headache worse. N stands for nausea and vomiting. Then you need to ask about symptoms that the triggers that might trigger migraine, which include the following: stress or hormonal changes, particularly in women. Usually migraine headache occur in the first 3 days of the menstrual cycle. Number 3, also not eating. Number 4, weather change. For example, if there is wind or sudden change in the weather, the patient with migraine, they might have migraine attack. Sleep disturbance, exertion, using perfume, or if there is an odor, presence of light, smoking, heat, or food, certain foods such as cheese or chocolate or fried stuff, that all might trigger migraine. Also, you need to ask about migraine aura, such as visual aura, which is basically called scintillating scotoma or flashing light, or sensory aura, meaning numbness or tingling, or olfactory aura, or language. Language include aphasia or dysarthria. However, if the aphasia or dysarthria occurred for the first time with migraine, then you have to deal with the case as acute stroke case. You don't consider this migraine aura. When do we consider this migraine aura? If it occurred several times in the past, 2 or 3 times with migraine in the past, then you might consider this as migraine aura. However, if it occurred for the first time, you need to deal with it as acute stroke, and you order CT brain and the rest of acute stroke workup. Similarly, if the patient experienced ataxia and vertigo, if it occurred in the past, that could be considered as migraine aura. If it occurred for the first time, you need to deal with it as acute stroke, and you get the CT brain or MRI, and you complete the acute stroke workup. Then you ask about symptoms of tension headache. And tension headache is called also featureless headache, and the feature of tension headache are exactly the opposite of migraine headache. So usually, number 1, it's pressing or tightening headache, non-pulsating. Number 2, it's mild to moderate intensity, so the patient can continue his daily activity. It doesn't prevent the patient from doing the daily activity. Number 3, it's bilateral. Number 4, not aggravated with routine activity. Number 5, not associated with nausea or vomiting. Number 6, not associated with photophobia or phonophobia. Symptoms suggestive of cluster headache include number 1, restlessness, which is very important feature, because usually migraine headache, they are the opposite. They like to go and sleep and lie flat. However, patients with cluster headache, they are agitated. They move around. They look agitated and restlessness. Number 2, unilateral eyelid swelling. Number 3, unilateral nasal congestion. Number 4, unilateral tearing. Number 5, unilateral runny nose. Number 6, unilateral red eye. Then we move to examination. So what are the red flags in the examination? First, blood pressure. Elevated blood pressure make you think of hypertensive encephalopathy or breast posterior reversible encephalopathy syndrome. High temperature make you think of meningoencephalitis. Confusion make you think of meningoencephalitis, cerebral venous sign thrombosis, or intracranial hemorrhage, or acute stroke. Number 3, neck stiffness make you think of meningoencephalitis and subarachnoid hemorrhage. Pupils. If the pupils is small and doesn't get larger in the dark, you think of Horner syndrome due to carotid artery dissection or vertebral artery dissection. If one of the pupils is large, dilated, or non-reactive, you might think of subarachnoid hemorrhage due to the presence of PCOM aneurysm. As we mentioned, posterior communicating artery aneurysm might compress over the third cranial nerve, and that will result in dilated pupil. The other sign is papilledema, which might indicate raised intracranial pressure, such as cerebral venous sign thrombosis, or due to IIH, idiopathic intracranial hypertension. Also, you ask about vision loss and transient visual obscuration. Vision loss can be a feature or manifestation of hypertensive encephalopathy due to posterior reversible encephalopathy syndrome, due to non-cytotoxic or vasogenic edema in the occipital loop. Also, you look for ophthalmoplegia, like restricted ocular motility, restricted the range of eye movement. That make you think of pituitary apoplexy, which is basically pituitary macroadenoma that have ischemia and hemorrhage inside the pituitary gland. Also, you look for any focal weakness or ataxia or incoordination, because that might indicate presence of stroke or subarachnoid hemorrhage, or subdural hematoma or cerebral venous sign thrombosis. So another emphasis on the assessment of attention. We need to make sure the patient is not confused and not encephalopathic. So first, you can, for example, give him 5-digit span. So you give him 5 numbers, such as you say 5, 7, 9, 1, 3, and the patient say again 5, 7, 9, 1, 3. So also you might ask him to count backward from 20 to 0. 20, 19, 18, 17. If the patient can continue to 0, that's a good. If the patient stop in the middle, that means the patient cannot maintain the same task and is confused. Also, you might ask the patient about simple math, like subtracting 7 from 100. So 100 minus 7, 93. You tell him also subtract another 7 from 93. He should say 86. Then ask him to subtract 7 from 86. That will be 79. Then ask him to subtract 7 from 79. That will be 72. So if the patient is able to do that, that means the patient is less likely to be confused. If the patient is not able to do that, that might be an indication of the patient confusion. However, older people, you might not ask him to do 100 minus 7 because they might not be able to do it. So for older people, you just ask simple math. For example, 5 plus 6, he or she should say 11. Also, you assess the patient. Can the patient carry a coherent conversation or not? Because usually confused patients, they cannot carry coherent conversation for longer period. Also, you look for meningismal signs. First one, the famous sign, Kerning sign. So if the patient is in the supine position, you flex one leg at the hip, then try to extend the knee. The positive signs, if the patient has pain in the neck or resist the attempt to extend the knee. Also, the another sign is called Brodzinski sign. All these signs indicate meningoencephalitis. So you flex the neck, and the positive signs if the patient flex the hip and the knee automatically. So these are features of meningoencephalitis. Then we proceed to investigation. The investigation should be guided by your history and examination. And what do you think of? So you order CT brain or MRI brain if you think, particularly in the acute situation of hypertensive encephalopathy, if you think of subdural hematoma or subarachnoid hemorrhage. However, usually if the patient comes to the clinic with headache and never had image, it's preferable to order image for all patients who comes recently with headache with no prior imaging. However, if the patient has any red flag, all patients with the red flags in the history examination, they all should get CT brain or MRI. Cerebrospinal fluid, CSF, if you think of meningoencephalitis. CTV, CT brain venogram, if you think of cerebral venous sign thrombosis. CTA, CT angiogram, if you think of posterior communicating arterial aneurysm or dissection. Also, if you think of RCVS. You order ESR and CRB if you think of giant cell arteritis, particularly if the patient is more than 50 years old with jaw claudication and transient visual obscuration. What are the cutoff for giant cell arteritis? These are rough rule. ESR more than 50, CRB 20 or more. We are talking about CRP proper, not high sensitivity CRP, because that has different cutoff value. But for CRP, it's more than 20. For ESR, more than 50. For platelets, it's more than 300. These are general rules and should be interpreted within the clinical context. So if you have history very suggestive of giant cell arteritis, you might not follow all these cutoff values. we need to have extra emphasis on the following scenario. First, new onset or persistent vomiting, you need to check for raised intracranial pressure, such as acute hydrocephalus, if there is mass in the ventricles or enlarging mass in the brain parenchyma, because you need to look for signs of raised intracranial pressure, and you need image to rule out acute hydrocephalus or enlarging mass that might lead to herniation. So the second thing, if the patient is female, particularly overweight, with either double vision or transit visual obscuration or pulsatile tinnitus, that make you think of idiopathic intracranial hypertension, and you need to get MRV to rule out venous disease such as cerebral venous sign thrombosis, or also you need to order, if there is no brain mass, to order lumbar puncture to measure the CSF opening pressure. And other thing we need to emphasize, if patient is female and taking oral contraceptive, you need to rule out cerebral venous sign thrombosis with CT venogram or MRV. And headache in pregnant woman or in the postpartum period, you need to think of eclampsia and preeclampsia, also cerebral venous sinus thrombosis, also acute stroke, either ischemic or hemorrhagic. As pregnant woman and postpartum woman, they are vulnerable to these things. If we rule out all secondary causes and we left with primary headache disorder and the investigation were normal, we need to treat migraine headache or primary headache disorder. So first line is to use NSAID, like such a non-steroidal anti-inflammatory, such as ibuprofen or diclofenac or paracetamol. The second line for migraine, specific treatment for migraine, is serotonin agonist or 5-hydroxytryptamine agonists such as somatriptan and elatriptan. However, you need to make sure that there is no contraindication, particularly cardiovascular disease such as history of acute coronary syndrome. Also, there are the new class of medication called CGRP inhibitors or calcitonin gene-related peptide inhibitor, such as uprogepat and remigepat. Also, you need to consider that most of the time we use the first and second and third line, we use anti-emetic or anti-nausea medication such as metoclopramide or ondansetron. If the patient comes to ER, you might need to use injectable medication such as IV fluid or IV paracetamol or IV or intramuscular NSAID such as ibuprofen or dexketoprofen, or IV magnesium or IV valproic acid, or rarely we might need to use narcotic. Then you might need to think of prevention in migraine headache, and there are several methods of prevention. First, supplements such as vitamin B2, riboflavin, or magnesium pills. Number two, antihypertensive medication or medication that control the heart rate, such as propranolol and candesartan. Number three, tricyclic antidepressant and antiepileptic medications such as amitriptyline and topiramate. Number four, the CGRP antagonist class, calcitonin gene-related peptide antagonist class, such as galcanezumab, atogimab, remigepat, and eptinezumab. The fourth class is Botox injection. That's the end, and thank you very much.